So infant hip dysplasia or developmental dysplasia of the hip is a developmental condition that occurs around the time of childbirth, and it really represents a wide spectrum, all the way from the severe form of the disease, which is a complete dislocation where the hip is completely out of the socket, to the mild form of the disease where the hip is in the socket, but the socket's just a little bit shallow. Contrary to what some people would think, even a full hip dislocation is actually not painful to an infant. Most infants that have hip dysplasia actually have no symptoms whatsoever. So if you're a parent, you're not going to tell that your child does or doesn't have hip dysplasia. Now, pediatricians, as part of their routine screenings, are always going to check for this. So they're going to move the hips every time they see the baby, and they're taught through their training to screen whether the hip is coming in and out of the socket. But the only way to actually diagnose that milder form of the disease, where the hip is shallow, is really by getting an ultrasound. It allows us to get really excellent pictures of the hip to understand what the anatomy looks like and what the position of the hip is. We can even test the stability under ultrasound. And really importantly, it does not require any sedation and does not expose the infant to any radiation. The goal when we treat kids with infantile hip dysplasia is to normalize the hip. First, we got to get the hip to settle deep into the socket. You can't achieve any of your other goals unless you get the hip to settle deeply in the socket and what we call concentrically in the socket. Once the hip is in the socket, our secondary goal is to get that socket to develop, to kind of deepen and cover the ball, because that's what really supports the longevity and the health of the hip as you move forward decades into life. We always try non-surgical treatment options, and generally those are quite successful. One of the most common devices is called the Pavlik harness. That's a Velcro strap apparatus that allows that femoral head or the hip to dock into the socket and helps promote that socket to develop. But that's really just one device. There are several other devices, some that are a little bit more rigid, some that hold the hips a little bit straighter, some hold them a little bit more bent, and we often use very different devices for different patients so we can get the right fit of the right device to try to really maximize our success rate with non-surgical options. The infant hip is a little bit like clay. You have the ball and you have the socket. And the way the ball knows how to form round is because the socket is forcing on it during early development. Similarly, the only way the socket knows how to form deep is if the ball is pushing on it. So all of these hip dysplasia devices encourage the ball to settle deep into the socket, and that pressure that the ball pushes on the socket causes that clay or the socket to kind of grow and deepen around the ball itself. What's really remarkable about hip dysplasia is that even in the setting of a dislocated hip or a severely shallow hip, the hips are growing so rapidly at this age and the babies are maturing so rapidly that even something like that can be almost completely normalized in 2 to 3 months, which just speaks to the rapid development and the fascinating ability to remodel of the human body. Now, even though non-surgical treatment is generally successful, there are obviously some situations where bracing doesn't work and a child has to have surgery. I tell all my families that we do the least amount of surgery to accomplish the goal. And the goal is to get the ball deep into the socket and to get that socket to develop as well as it can. So the first option once we put a child to sleep under anesthesia is a closed reduction. That means we are manipulating the hip externally without making an incision to put the ball into the socket. If, however, the hip does not go, or if it doesn't go in deeply, or if it doesn't feel stable after it goes in, then under the same anesthesia at the same time that the child is asleep, we make a small incision, we open the hip socket, we put the hip in under direct visualization, we get rid of all that stuff that's blocking the hip from finding its home, and then we close everything up. Regardless of whether you do a closed or an open reduction, once you get the hip into position, you have to hold it in that position. And that's where the spica cast comes in play. That's the body cast that goes from about the nipple line down to below the legs. And by holding the hip in that position, that allows that socket to mold around the ball and allows that ball to get used to its position. So depending on the surgical treatment that's done, the time in the spica cast can vary between 6 to 12 weeks. And there's no doubt that the spica cast is the most challenging part of the treatment plan, certainly for parents. We have a great team at CHOP, including a dedicated hip dysplasia nurse that spends a lot of time with the families, teaching them how to do clothing, how to do positioning, how to position for breastfeeding, how to get them into a car seat, and so on, so that the whole process is safe for the baby and as comfortable for the baby as it can be, and as comfortable for the family. For the vast majority of infants that have been diagnosed with hip dysplasia, who we identify early in life, who get treated with a brace or a harness, you can expect essentially a normal hip. Most of these kids do very, very well with normal childhood, running and playing all the sports that parents expect for them, and having a healthy, productive life. For those patients that need to go to surgery, the success rates are really quite high, but experience is absolutely crucial. Going to a high volume center where they take care of a lot of infants, both with closed reductions and open reductions, is really key. So we at CHOP draw patients from all across the country and all across the world, and they come here because of our expertise and our large volume in taking care of patients. We're a leading center at the Hip Dysplasia Study Group, and that's what's helped guide many centers around the country to figure out how best to treat their infants. I love taking care of infants with hip dysplasia. It's one of my favorite parts of my practice. And the reason is because I get to meet these babies at the time that they're born, and we can identify a problem, and non-surgically, we can often cure these hips. I really develop great relationships with these families. And it's really special for me when I see these babies that I knew, either in a cast or in a brace, and to see them and hear what they're doing when they're 13, 14, 15 years of age.